Good evening, aspirants. Today's class is on ideal critical care. Topic is CRRT in ICU. Organizers are as follows. Dr. Akhilesh Tandekar, he is the HOD Critical Care, Wokhade Hospital, Mumbai. Dr. Gunadhar Pari, Senior Consultant Critical Care Medicine, Apollo Hospital, Navi Mumbai. Dr. Asif Iqbal, he is the Senior Consultant Department of Respiratory Critical Care and ECMO Services at Apollo Multispeciality Hospital, Kolkata. So I request Dr. Akhilesh sir and Dr. Gunadhar sir to introduce the speaker.
Dr. Chatterjee is professor and consultant critical care specialist in Dayanand Medical College. He has vast experience of handling dialysis patients requiring continuous renal replacement therapy. He is a prolific speaker, fantastic orator, and he has in-depth knowledge of renal replacement therapy. Today, we are really fortunate to have Dr. Ranajit Chatterjee with us. Sir, we welcome you today for today's webinar. We will have a discussion for 45 minutes, followed by panel discussion at the end. And without much wasting time, I think can I request you to please start sharing your presentation, sir. Dr. Gunadhar,
thank you, Akhilesh, for your. Thank you. Yes, Gunadhar, if you want to say something.
Yeah, I think I can just only say sir is the best nephro-intensivist, one of the best nephro-intensivists in India. So try to learn as much as possible from him and extract as much as possible from him also by question answers. So he's one of the very prolific speaker, and I welcome sir.
Thank you, Gunadhar. Thank you, Akhilesh, for your kind introduction. And I am Dr. Ranajit Chatterjee. I'm the head of critical care of Swami Dayanand Hospital in Delhi, and I am going to talk on CRRT in ICU. So, my dear friends, renal replacement, especially the continuous form of renal replacement therapy, now is going to enter its around 30th year of regular use. Well, the first conference was held on 1996, and before that, the concept came well in advance, way back in 1943. I'll come to that. Now, see how we have gone from. This is a 2010 picture in my ICU, where I am using a machine which is the Prisma machine. This was the Prisma machine that was first used. A fantastic machine for CRRT. Then came the Prisma Flex. This is the Prisma Flex that has come up and which is now present in most of the ICUs here in India because the Prisma has been taken out. And this is the latest one, that is the Prismax machine. And this is from my ICU, that is the latest one that has come. You have other companies also, but this is the what I want to show you, that the gradation that has come up from where it is from this in 2010 to 2024. In this machine, the last one, we can also do extracorporeal CO2 removal. So this is the way we are progressing in CRRT, and slowly and steadily intensivists are getting acquainted with it, and they are getting that strength that yes, we can do it ourselves, and that what is needed today, because this man, Johann Kolf, who was way back in 1943, he did the first renal replacement therapy in a 63-year-old lady. When he started dialysis, he started with the washing machine's motor and the orange cans covered by sausage skin. That was the first time the dialysis was done. And in 1943, He did unknowingly. He went on doing dialysis on a patient, and he went on doing the dialysis for more than 13, 14 hours, and the patient survived. That was in 1943. The first prolonged dialysis was done. And slowly it was done arteriovenous. Slowly the veno-venous system came. That is, you take the blood from the same vein and push it in the same vein. Previously it was arteriovenous, then it became veno-venous. And then the continuous form came, where it was continued for 24 hours due to the reasons which I'm going to discuss. So this was the situation way back in 1943. And these are the machines that I've already shown you in the present day. So when I classify renal replacement therapy, I classify it into two parts, continuous and intermittent. Intermittent, as we all know, they are either peritoneal dialysis, sustained low efficiency daily dialysis, and intermittent hemodialysis. Whereas the continuous form, they are either continuous veno-venous hemodialysis, continuous veno-venous hemofiltration. If you combine these two, it becomes continuous veno-venous hemodiafiltration. And if you only do a bit of ultrafiltration, that is known as slow continuous ultrafiltration. So it basically works on the molecular mechanisms of diffusion, ultrafiltration, convection, and absorption. So what is diffusion? The movement of solids from a higher to a lower concentration area across a semi-permeable membrane. So this diffusion, basically the principle is used by hemodialysis, where only the small molecules mainly are removed from a higher concentration area to a lower concentration across a semi-permeable membrane. For example, you have high creatinine, high urea, high potassium, high sodium in the blood. Across the semi-permeable membrane, it will get diffused into the dialysis when you are doing a dialysis. Ultrafiltration and convection, they go hand by hand. So when you are moving that fluid, when you are moving these solids against a pressure gradient, a lot of fluid is moving. Along with the fluid, the solutes which are coming out, they are also draw a lot of water. So that is basically ultrafiltration and convection. So movement of the molecules against a pressure gradient across a semi-permeable membrane. So this concept is basically taken up by the prolonged therapies like the continuous form. And if you combine both of them, the diffusion and the convection, you basically make it a therapy which basically uses both the principles of dialysis and also the principles of ultrafiltration. And absorption basically is a molecular adherence to the surface of the interior of the membrane. So this is absorption. So on the basis of this, we have hemodialysis, where it is moving from higher concentration to the lower concentration. See, the blood and the dialysate, they are basically moving opposite to each other. This is counter current mechanism. Now we have hemofiltration. Will you please stop talking behind, because I am getting disturbed. Please. Or please mute yourself. Please. So now hemofiltration basically is where you are taking out that extra amount of fluid. Remember, when you're taking that extra amount of fluid from the patient, you have to replace it also back to the patient. You are taking that pathological fluid from the patient and replacing it with a physiological solution. Because if you suppose removing 2 liters per day from the patient, extra amount of fluid, so the patient will become dehydrated. So you have to replace that also. Now you can replace it before the before the blood enters this is the way that before the blood enters the filter, or when the blood is coming out after the filter, after it comes out of the filter, there also you can replace it. I'll request, please, if somebody stop talking behind, and I request the organizers, why don't you switch off the audio of everybody? How can I talk like this?
Yes, sir. Yes, sir.
Please. I'm getting disturbed. The flow is going off. So I was here. Let me start again. I was with hemodialysis, where you are moving the small molecules from higher concentration to lower concentration across a semi-permeable membrane, and the blood and the dialysate are moving opposite to each other. That is, this is a counter current mechanism. Hemofiltration and hemodiafiltration, you not only remove the molecules, but also a lot of water along with it. So that is the reason you have to replace that fluid to the patient, otherwise the patient will become dehydrated. And accordingly, you have all this. You have either slow continuous ultrafiltration, where you are only doing a bit of ultrafiltration, you are not replacing anything here, because you want to remove that extra amount of fluid either from the pulmonary circuit or from the cerebral circuit, or in hepatic encephalopathy, the extra amount of fluid that is being accumulated in the body can be removed. In CVV HDC, you don't have to replace anything because only the small molecules are going out. The moment you come to ultrafiltration, you are replacing the fluid. So this you have to understand why we are replacing the fluid and where we are replacing the fluid. We are replacing either when the blood is entering your filter, before that is pre-dilution, or when it is coming out of the filter, that is post-dilution. If you inject the fluid before the blood enters the filter, you basically dilute the blood. The moment you dilute the blood, what will happen? This will decrease the clotting of the filter, but definitely it will compromise on the convection because you have diluted the blood. In a post-dilution, the convection is never compromised, but there is chance that the filter gets clotted very quickly. So what we do, we divide it between pre and post, maybe 1/3 and 2/3. Somebody divided half and half. It depends on the situation of the patient. And normally what I do, I divide it into 1/3 and 2/3. 1/3 pre-dilution, 2/3 post-dilution. There are different type of replacement fluid. Nowadays we are using commercial fluids which are based on bicarbonate. And there are acetates and lactate-based fluid also, but we are not using them. We are using bicarbonate-based fluid. Now, the modality, that is, suppose you have to remove only volume. For example, you have pulmonary edema, you have congestive heart failure, you have cerebral edema. So there you have to remove only that extra amount of 200 or 300 or 500 ml of fluid. There you just remove it by doing slow continuous ultrafiltration. I'll come to that when I discuss the prescription. Now, when you are removing solutes plus volume, then either you can do a hemofiltration or a hemodiafiltration. So if you are removing only the dialysis, you are only removing the solutes, you can do hemodialysis. You want to remove a bit of volume, fluids, extra solvent, do a hemodiafiltration or a hemofiltration. And in a hypercatabolic state like sepsis, we start with hemodiafiltration, and then slowly we move to either hemodialysis or hemofiltration. Basically, this is a jugglery between hemodiafiltration, hemodialysis, and hemofiltration according to the situation of the patient, according to the condition of the patient. I'll come to that. So the most important part of CRRT, is to put a catheter. If you don't put a catheter properly, your dialysis will fail immediately. So the person who puts the catheter the best, he should be, and I have seen it, rather than the consultants, the residents there put the catheter better. So either it may be put in the right internal jugular or the femoral. The best part is the right internal jugular because they have a pull of blood in the form of right atrium there. And if we're putting in the femoral, at least go 20 centimeter inside the vein, because otherwise there will be recirculation inside the catheter. Whereas you're putting in the right internal jugular, you can go up to 11, 12, 13 centimeters, and they're put in by ultrasound guidance. So 11 to 14 French catheter, normally we use around 11.5 to 12 French catheters. They're good enough to do a very good CRRT because the flow is very important. You can see you have a access line, which is basically the red, and the return line is the blue. The blood with the pump, it is sucked out from the access line, so there is a negative pressure there. And after filtration is put back by the blue line, that is the return line, into the patient. And the right internal jugular vein is, as I told you, around 15 centimeters, and the length of insertion in the femoral is around 20 to 24 centimeters. So this is the anatomy of the hemofilter, where you have a lot of hollow fiber membranes. Outside the fiber, the dialysate and the effluent and that is the fluid that we want to remove, that is there. And inside the fiber, there is blood. And obviously, the semi-permeable membrane lies in between. And we we basically, I'm sorry, we basically do this filtration. The hemofilter is very important because if it gets clotted, obviously the quality of a filtration will definitely get compromised. So different type of filters are there. The dialyzer membranes are there. It may be unmodified cellulose, modified cellulose, synthetic membranes. They started with unmodified cellulose. Now they've gone to the synthetic part, which are least incompatible. That is, they're very good biocompatible. The reactions are not there. Good absorptive area, good surface area. The pore size are big, so you can remove the middle molecules from there. Previously, if they are not coated, these AN69 membranes, if they're uncoated with polyethylenamide, when you used to start the CRRT, there was sudden hypotension and pulmonary congestion. So this used to occur in patients with severe acidosis, or those who are on AC inhibitors, or those who have the circuit described with blank blood. This is not a problem nowadays, but sometimes they might, some senior examiners might ask you about this bradykardite release syndrome. So I thought I should share this with you. So remember that in order to preserve this filter, you have to do some anticoagulation. And this anticoagulation is one of the shortcomings of CRRT. Either you can do it unfractionated heparin, we normally follow that, or you can use a citrate, which is normally followed in nowadays in most of the centers. But citrate had its own problem, and heparin also has its own problem. If you are normally we are not using low molecular heparin or prostaglandins. These two, unfractionated heparin and citrate, are used. If you are using unfractionated heparin, the dose is around 5 to 10 units per kg per hour, and you have to keep your APTT between 45 to 50 seconds. And you have to measure the APTT every 6 hours. That means either your laboratory should be there to do that APTT every the whole 24 hours, or you yourself should have a machine inside the ICU to see that. Normally, we also can do a thromboelastogram to see the dynamic coagulation parameter in these situations. Those who have it, they're lucky, and they should be monitoring with a thromboelastogram. Citrate is a regional anticoagulant, whereas the heparin is a systemic anticoagulant. It goes inside the patient, so obviously the patient's own coagulation parameters are affected. Citrate basically is not going in, it goes inside the patient, but it gets converted into bicarbonate. So when citrate is going inside the patient, it gets converted into bicarbonate to the liver. There is a lot about a metabolic alkalosis. Now, if you are using citrate and you are developing a metabolic acidosis, that means you have a liver failure. So either the liver is not functioning, or in hepatic encephalopathy, in hepatic compromise, we should not use citrate. I'm not going into the details of this citrate because in 45 minutes it's not possible. But those who are going for your exams, you should read how much should be the post-filtered ionized citrate, what should be the dose of the citrate, you should know about it. Now, where should I use CRRT? CRRT, the concept basically, because it's a very smooth type of therapy, so mainly used in hemodynamically unstable patients. And your ICU critically ill patients are all hemodynamically unstable, are all on vasopressors. So where the blood pressure, the mean arterial pressure is quite low, there you can't go for the intermittent therapies, because they will definitely go for a lot of hemodynamic compromise, hemodynamic undulations. Similarly, precise volume control, drop to drop fluid that you are giving, you are also replacing. You exactly know how much amount of fluid you are dealing with. Very effective control of uremia and potassium in hemodynamically compromised patients. It controls the metabolic acidosis because the fluid that you are giving is bicarbonate based. It controls metabolic acidosis well. Very safe in brain injury, especially in dialytic resistant pulmonary edema, as we are telling you. And as an adjuvant therapy in sepsis, where you have a chance to remove the middle molecules, you're there. And possibly there is an advantage in terms of renal recovery. This has been seen mainly in observational studies, where they have compared CRRT with SLED or IHD. Have seen that patients who are on CRRT, they have a better renal recovery and does not land up into chronic renal disease in the future compared to those of its intermittent counterparts. So this part is basically why CRRT is used, and in these situations, they're used. Remember, you are maybe dealing with a lot of nutrition. Fluids, you are giving a lot of fluids to the patient in the form of nutrition. And you can take out that extra amount of fluid also, if you can collect it. And also CRRT itself, the fluid itself, provides a lot of calories to the patient. So CRRT basically is not only a renal replacement therapy, it gives support to all the organs, which is the brain, liver, lungs, the heart, or the gut, because that extra amount of fluid that is taken out from the patient. And I'll come to them one by one. And it corrects the acid beta abnormalities, the electrolyte disturbances, good fluid management, inflammatory markers. It's a fantastic temperature regulation is there, because the patients who are hypothermic, this CRRT causes a lot of hypothermia. So in malignant hypothermia, sometimes CRRT is used as a treatment. And obviously the metabolic adaptability. So I term it as a constant organ support therapy. It is not a CRRT, renal replacement. It is organ support that you are giving. So do not confuse chronic continuous renal replacement therapy with a chronic system. It is basically neither an intermittent one, neither for chronic renal failure, neither for acute renal failure only. This jinx has to be removed from your mind that renal replacement therapy means dialysis. It is only for AKI, acute kidney injury. It is not like that. It is dealing with so many things. Acute kidney injury is only a small part of it. So that has to be remembered. So when you are using CRRT, you should keep all these things in your mind. Now, in acute kidney injury, so when you are using CRRT in acute kidney injury, especially in sepsis, when the patients are coming up, as you know, the criteria, the Rifle, Akid, and the KDIGO staging, you all know. So normally, if you are in the stage case 2 or in the early stage 3 with a metabolic acidosis, with a fluid overload, dyselectrolytemia, you start CRRT. Normally, we start at a dose of 20 to 25 ml per kg per hour of effluent volume. I'll come to that, why you are using effluent volume. And either you use heparin or citrate as an anticoagulant. Now, stuff, that what I was telling you, if you are in special of pulmonary edema, cerebral edema, just it may be life-saving. For example, patient coming to you with a severe pulmonary edema following preeclampsia. And in the middle of the night, you have to remove that extra amount of fluid from the patient. Your blood pressure is nowhere, you can't find it. It's around 60, maybe the systolic. You just come give diuretics because the patients may be most of the time resistant to diuretics in the severe metabolic acidosis. Along with that, you have a low blood pressure. You'll be fearing to give diuretics. So what you expect, you give some amount of vasopressors and you pray that let the blood pressure come up so that you can use some bit of diuretic to take that extra amount of fluid out. So here scuff comes into play. Just 3 to 4 hours of scuff, removing that 2 to 300 ml per hour of extra fluid from the patient. By the time morning, the patient comes up, the patient will be out of your ventilator and the patient will be safe. And it is like a miracle it occurs. Those who have used it, they know that scuff works as a miracle in these situations. And this is one of our case reports where even the gynecologists give the name to the patient, Miracle Maya. I always tell this to everyone. The name of the patient was Maya. The gynecologist came in the morning. She thought that the patient is out. Patient is not there. And she told it's a miracle. Really, it works as a miracle if you're using it properly. Now, a patient comes up with your acute brain injury. Now, again, there is a lot of crosstalk between the brain and the kidneys, between the liver and the kidneys. All the organs are talking with each other. And in this situation, when your brain is injured, the kidneys also sometimes get affected because you have CR, you have CSWs, you have SIRS, you have sympathetic hyperactivity of the sympathetic system. So there the kidneys get injured. You may land up into acute kidney injury. And once you land up into acute kidney injury, again, you have brain cell acidification, activation of the innate immune response, alternation in drug pharmacokinetics, accumulation of neurotransmitter or deletion of neurotransmitters. So that is again injuring the brain. So that extra amount of fluid that has been accumulated has to be taken out. But see, the dose varies. Here the dose was 20 to 25 ml where you have kept it. Here the dose comes down a bit of less ultrafiltration. Here it comes down to 30 ml per kg per hour. Here, maybe you need a higher dialysate sodium, lower bicarbonate, lower blood flow. You have to start it a bit early. So here, you don't wait, in ABI, in acute brain injury, you don't see the criteria of AKI. Your patient is in acute brain injury, in cerebral edema. You have done suppose in the bedside, you have done an optic nerve sheet diameter, seeing that it's exceeding 6 or 7 millimeter, start CRRT. Don't wait. So, and with a low ultrafiltration, you are going for either scuff or a CVVH, low CVVH. Similarly, in acute liver failure, here the main problem is ammonia. So, you have to remove that ammonia. Here, see, the dose has completely changed. You have gone to a 50 ml per kg per hour. So if you go for such a very high ultrafiltration, you have a chance of what? The patient might land up into severe hypotension. So first of all, hemodynamic stability has to be maintained, followed by a high dose of ultrafiltration. So see how it is changing. It is changing from AKI to it is coming to scuff, maybe 200 ml per hour in a pulmonary embola, in a pulmonary that is edema, where you are going maybe for scuff of 400 ml per hour, you are removing. To ABI, you are going for a slow ultrafiltration of 13 ml per kg per hour. To acute liver failure, you go for a post dilution, either CVVH or CVVHD of 50 ml per kg per hour. So the dose is not constant, and the modality is constantly changing. So that is the reason, if you are using it, the way you are using it, that is the reason why the success of the failure depends on CRRT. So it is the clinician who is using it by the bedside. It is depending on him, not the machine, that how he utilizes his machine properly. So that is the reason in sepsis also, where you are not only using for AKI, but also for fluid and electrolyte management, for that cytokine removal, metabolic control, and improve energy balance. So even if you are using it, if your CRRT, normally now we are using those fluids which are not having glucose. They also may have glucose. If you're giving glucose, you are using citrate, you are using this, all will give you some amount of energy to the patient. So it provides a bit of nutritional energy that is needed for the patient. That is also being provided by CRRT. So it is a multifaceted system that is being used on patients. And see, when you're using CRRT, many people go for high volume hemofiltration, and you're removing those cytokines, you're leading to metabolic adaptation, mainly the IL beta, IL 6, all these things. TNF alpha normally is not removed, the molecular bigger one. You can give energy supply if you have in the fluid, you have glucose, citrate, and lactate, you could go up to 1300 calories per day. You don't have to give extra calories to the patient. Anticoagulation. Now, here the question comes, many of the person ask me, why myself, most of the time I use heparin. They ask me, why you are using heparin? Heparin is an anticoagulant that goes inside the patient, that disturbs the whole coagulation system. Remember, sepsis is a pre-DIC stage. If you have a thromboelastogram with you, in the initial stages, you will see there is a huge graph coming. That means a lot of coagulatory factors are being utilized by the body, so that they jump into a DIC, fulminant DIC stage, where you have no coagulation factors to basically start that clotting process. So if I can stop that in the beginning, that might be helpful. So if you have a CRRT, if you have a thromboelastogram with you, you can see the graph, and you can use heparin properly, and it is also an anti-inflammatory. Citrate is very good, but those who are using citrate, ask them, they have to give the whole fluid pre-dilution. If you are giving 1 liter fluid pre-dilution before the filter, what will be the quality of your hemofiltration? The quality is greatly decreased. Moreover, most of these patients are having some amount of hepatic dysfunction. Citrate going inside does not change into bicarbonate, and metabolic acidosis occurs, and that increases mortality. So both the pro and the con of heparin and citrate is there. So you have to utilize it judiciously, and that is the way why it is used in sepsis in this way. Now, a crosstalk between lung and your kidneys. As we know, if there is ARDS with AKI, the mortality jumps from 20% to 41%, doubles. So what can we do? Only one thing that we have achieved till today, is a low tidal volume. And by 2014, after the Proseva trial came, the prone positioning.
So I think Dr. Chatterjee has just logged out because of some technical issue. So by the time we will be logged in again. So to take this discussion forward now, there are a lot of literatures and there are a lot of studies which suggest that in a patient who is hemodynamically unstable, particularly the CRRT plays a very important role. And patients who are on very high dose of inotropic support and on multiple vasopressors and who are hemodynamically unstable, and these patients that usually they don't tolerate the conventional dialysis, and that is the reason the use of CRRT in such scenarios in the ICU is actually increasing. So before starting the CRRT, so there are very few basic things which we should all remember, like what is the indication. The first indication is whether it is a renal or non-renal, and whether it is a classical or there is some non-classical indication. So particularly if you see it is a renal indications, the take home is very pretty clear. Any patients with AKI with hemodynamic instability and with any classical indications of dialysis, like particularly fluid overload, metabolic acidosis, hyperkalemia. So these are the three the situations where the CRRT is indicated, particularly in hemodynamically unstable patients. So when we think about the particularly the non-classical indications, so in those situations, particularly we should think of, like, one is liver failure, one is the poisoning, okay, one is malignant hyperthermia, and of course there are very recent lot of literature are coming up in cytokine removal, where along with the CRT you can attach a filter and we can remove the cytokines. I think sir has joined, so once you will finish the talk,
Yes,
then we'll
I'm
take.
sorry. Can you hear me? Can you hear me?
Yes.
I'm really sorry. Actually, the light went off. Sometimes it happens here in this part of the world. And if I again, if it even goes up, please wait for me for another 1 or 2 minutes. So as Gunadhar was telling, that there are a lot of indications of CRRT which are beyond AKI, and obviously poisoning is there, fluid overload is there. One of these novel indications is this one, which I'm telling you about the ARDS patients, where the mortality doubles. And there you have to, what we have learned that we have compared 6 ml with 12 ml, not with 7, 8, 9, 10, 11. Directly 12 ml, 2000 paper. We are still hovering on it. There was a great debate with me, with Rahul Pandit this time in here in the ARDS day on driving more all adapted driving pressure without created that 15 ml the pressure of 15 below 15 will basically help in your in decreasing your that is mortality. But there is no RCTs on that. Whatever it may be, we are now only related to tidal volume, and if I decrease my tidal volume, the PSCO2 rises, and increase in PSCO2 beyond 70 obviously will cause mortality, high rise in mortality. We know this one. But we have given the terminology permissive hypercapnia. Why? Because permissive, the word itself means in Oxford Dictionary, permission with some amount of suspicion. We are not allowing, we don't want to allow it. But as we don't know how to remove it, we have permitted it. And we have given this glossy terminology, permissive hypercapnia. Seeing permissive hypercapnia, permissive hypoxia came up. Permissive now, uremia has also come up. Permissive hypotension was already there. So we are permitting everything. So it is not right. So how can I take out that extra amount of carbon dioxide without decreasing and without increasing the tidal volume? We can do a ECOR. This is the ECOR that is going on in. Now you have the Prismax machine where you can directly do the ECOR. Here, this is the Prismaflex in my ICU. See, we are using a neonatal oxygenator attached to the CRRT machine. Here, we are taking out the extra amount of carbon dioxide from the patient with the help of this neonatal oxygenator. And you can decrease your tidal volume from here to even up to 3 ml per kg body weight. 4 ml and up 3 ml. So supernova trial, they have decreased up to 4 ml. Extravent trial, that gone up to 3 ml. And this you can do with the help of ECOR. Now, these are the novel indications of CRRT. Alphos poisoning, I have also used in alphos poisoning, is a problem. It's a menace in North India. we have used because that metabolic acidosis is very quickly corrected. Temperature management, hyperkalemia, dysnatremias, hypercalcemias, and crush syndrome, tuberculosis syndrome. There also CRRT is used if they're used judiciously. Now, we have certain adjuvant therapies that can be attached to this, like the cytosorb, the toriamycin, the oxyris, especially in cytokine storm, cytosorb, because they remove mainly the TNF alpha and the IL-10, that is the bigger molecules, they can remove those, and they can also absorb those. They can be attached with the CRRT. Now, when to start? There is a question, early or late. Now, what is early? Nobody knows. Urea, there is level of urea, level of creatinine, urine output, rifle, KDIGO, P plus, or the biomarkers. People are confused. So there is nothing called early or nothing called late. It is a dynamic acute illness. Everything is changing in minutes. You know the rifle criteria, the KDIGO criteria, the Akin criteria. I'm not going to the details of this. We can't just say that we'll start in stage 1, stage 2, or stage 3. Nobody can give a blanket guideline. And again, remember, guidelines are not guidelines. Guidelines are basically just to give you some ideas. You can anytime deviate from that. So from 2016 to 2021, these 5 studies came. Alien trial, Akiki trial, Ideal ICU trial, Start AKI trial, and Akiki 2 trial. Alien trial only, it was in favor of early RRT. If you see the slide properly, see in Alien trial, the first trial, 90-day mortality was 39.3%. They started in KDIGO 2 compared to 54.7% in late RRT. It was a single center trial. So that is the reason it basically fell out of favor. When Akiki came, see the same thing they started in KDIGO 3, the mortality is 48.5%. That means a jump from 39.3% to 48.5%, 10% difference. This nobody looks. People only go, oh no, there is no difference in mortality, 48.5 versus 49.7. But see the difference between LA and Akiki. It's a 10% difference. So, and Ideal ICU trial was stopped early. Start AKL trial was a very good trial. And it was basically took a lot of patients. But here a peculiar thing was taken. Clinical equipoise. Clinical equipoise is sometimes good. Clinical equipoise means so the clinicians come into a common consensus. So in that situation, you can hardly understand how the clinicians come into consensus. It's very difficult. So 7,000 patients has to be excluded from the trial because nobody came into the consensus. And ultimately they found that again the mortality is around 43 to 44%. Akiki True trial. Basically, what was late for Akiki was early for Akiki 2. That means it was too late. It started too late. And it told, no, too late is not good. So, what to do? We are confused, but see, this is only for those who are in acute kidney injury. This is not for the other indications. This is only for those who are in acute kidney injury. What I do? Normally, if you are in AKI, then first of all, I try to optimize the volume, give meal arterial pressure, cardiac output, intra-abdominal pressure. I see those things. And I see whether the patient is KDIGO 2 or KDIGO 3. If even after optimizing, my patient is worsening rapidly, having refractory fluid overload, severe sepsis, ARDS, or a hypercatabolic state, I don't wait. I start. But if the patient is improving, is not in that hypercatabolic state, I wait till KDIGO 3. Or if you have any other indications apart from AKI, if there is no AKI, you have refractory fluid overload, hypothermia, ARDS, acute liver failure, electrolyte imbalance, tumor lysis syndrome, you start CRRT. Don't wait for AKI to occur. So this is how we go for it. Now, this is the most important part, the dose of CRRT. You have to understand this. Now, dose of IHD is KT by V urea. That is, K is the efficiency, volume of blood cleared of a given solute over a given time. K into T is the intensity, clearance into time, and KT by V is divided by the volume of distribution. That is the fractional excretion of a given solute. They have taken urea as the marker here in IHD. Now, see, this is very good for a patient who is having a chronic kidney disease, having a stable volume of distribution, coming in his or her mark, coming and sitting in a lean chair, having a cup of coffee in hand, and having a dialysis. This is very good for him. But a patient who is lying down, patient who is intubated, patient who is ventilated, patient whose volume of distribution nobody knows, where you're scratching your head how to save the patient, the blood pressure is not recordable. There, this formula does not work because the volume of distribution is so uncertain and you have an unstable metabolic state. The fluid volumes are labile. Moreover, you might have some possible residual renal function which is there. And you are using vasopressors. You're basically, the whole metabolic milieu of the patient is changed. So these are the reasons why this formula is not applicable in CRRT. What we see in CRRT, we basically take the effluent rate. And the effluent rate, the clearance is measured inside the effluent rate by seeing the sieving coefficient. Now, what we do basically, we take the fluid from the effluent, we take the fluid from the blood. Suppose I measure urea in effluent and measure urea in blood. And if this ratio is 1, that means I'm doing very good CRRT. If it's coming down, that means my CRRT is also, the level is also coming down. That is, everything is diffusing. Then this value will be 1. Ratio of the effluent to that of the blood. So that is the reason effluent rate is taken as the dose. So total dose is the effluent rate. That is, the DR is the dialysate rate. Ultrafiltration is the UFR. So total dose is dialysate rate plus ultrafiltrate rate. For example, if the dialysate rate is 1000 ml per hour, ultrafiltrate or the replacement, remember, whatever your replacement fluid you are putting, you are taking that out also from the patient. So that is the reason I am bringing replacement fluid. So 1000 plus 1000 is 2000. In a 50 kg individual, it becomes 2000 divided by 50, that is 40 ml per kg per hour. Now here, whatever the dialysate with the ultrafiltrate rate is there, that is the effluent rate, so it is zero balanced. Now suppose you are removing something over an extra, which you are not giving back to the patient. This is known as net ultrafiltration or patient fluid removal. In one machine, it is called patient fluid removal. In another machine, it is called net ultrafiltration. Suppose you are giving 100 ml per hour. So now your total effluent that is in the bag, what will come? 1000 of dialysate, 1000 of ultrafiltrate, and 100 of patient fluid removal. So it becomes 2100 ml. But your dialysate and ultrafiltrate is only 2000. So now it becomes 2100 divided by 50, that is 42 ml per kg per hour. Now here, the effluent rate is more than that of the dialysate or the ultrafiltrate. So it is a negative balance CRRT. You are doing a negative balance. Now what is cuff? Just leave dialysate 0 and ultrafiltrate 0. Only remove patient fluid. That is cuff. Now you have to do CVV HD. Keep dialysate 1000. Make ultrafiltrate 0. It is CVV HD. CVV HF. Make dialysate 0. Continue ultrafiltration. It is CVV HF. So only in one modality you can shift from CVV HDF to CVV HD to CVV HF and to SCUF. So this you have to understand. Those who are doing it, they know about it. Those who are not doing it, if you understand this, the basis of CRRT will be clear. Now, how much blood flow should I give? Everybody asks these questions. Remember, if you are doing it only CVV HD, you can start with a low blood flow. It is basically the amount of dialysate that is per minute. For example, 2000 ml per hour of dialysate you are giving. That is 2000 divided by 60, around 33 ml per minute. At least 2.5 to 3 times of that. Maybe 83 ml per minute of blood flow has to be given if you are doing minimum. So we start around, if you are doing CVV HD, you start around, maybe we can start with 100, 120, it's fine. But moment you go for an ultrafiltration, you have to increase your blood flow. So if you are giving a pre-filter ultrafiltration, because as you are diluting it, so you have to give a more blood flow to make it more efficient. So it should be at least 6 times that of your pre-filter. So suppose your pre-filter is 33 ml per minute, so into 6 should be your blood flow. If it is post-filter, at least 5 times. So when you are at the point is, if you are doing for ultrafiltration, you have to increase your blood flow. And remember, many people think that increasing the blood flow will decrease the blood pressure. This is completely a misconception. It is basically the ultrafiltration rate, which basically decreases the blood pressure. Now, this is the crux of CRRT, this slide. Because people fail here only. So suppose you want to remove some amount of extra fluid from the patient. So suppose I want to remove 100 ml from the patient. But so net fluid removal hourly, I want 100 ml. But I am also giving something IV, maybe 100 ml IV, maybe total parenteral nutrition. So I am giving, suppose 100 ml from outside. So that becomes 200. And maybe 50 ml is coming out in urine. Maybe something is coming out in drain. So the whole thing has to be calculated, and then that patient fluid removal has to be set in the machine. For example, Mr. X, a 50-year-old male with a CRRT CVV HDF on day 3, intensivist, want 100 ml per hour to be removed.
So I hope this what sir told in the last slide. This is very, very important. So suppose normally what we assume that if you want to remove 100 ml net fluid balance from the patient. So if you set a fluid removal of 100 ml, we think that usually the fluid balance can be achieved. But actually it is not that. So what sir has told just now actually. So you have to calculate the net intake of the fluid into the patient and the net output what the patient is throwing either in the drain or the urine, and from that you if you want to keep 100 ml negative every hourly, so you have to add your 100 ml to the net input and then you have to subtract the net output. That is what actually the fluid removal rate actually. So it is not actually 100 ml, and as in the last exam, in the last example, it might vary from 200 to 250 ml to sometime goes up to the 300 ml. So it all depends on your calculation, like particularly what you intend and what your patient is receiving and what is your output actually. So this is what the overall crux. And going before the last slide actually, before that slide, so whatever is sir told, particularly regarding the dialysate rate and the something called as the ultrafiltrate rate and the blood flow rate. So these three are very, very interdependent. So these three are very, very interdependent, particularly in a scenario. For example, I'll tell you, for example, suppose you have kept a dialysate rate. For example, you want to achieve a dialysis rate or of around 1 liter, for example, or you have set a dialysate rate of 1 liter particularly. So in those cases, your blood flow rate should be ideally the 3 times per hourly basis the dialysate set rate. And second thing is also suppose you have want to also suppose you are simultaneously you have just increased the ultrafiltration in that particular machine. So in that case, your blood flow rate should be ideally 5 to 6 times actually. So this is how the correlation. So the whole crux of the story is that if you want to have more ultrafiltration and more dialysis, so obviously you have to increase your blood flow rate corresponding to your dialysate set rate and ultrafiltration rate what you want to achieve actually. The net prescription of the such dialysis patient, it depends on what your UFR you have set. For example, suppose you is a 50 kg patient and you want to set a prescription for that particular patient. So what is important is how much your effluent flow rate you want to set. That effluent flow rate means that is called the prescription. So normally there are a lot of studies which found that if you want to set the effluent flow rate between 25 to 30 ml per kg and 30 to 35 ml per kg, so it doesn't vary much actually. So the standard, if you want to remove the effluent at a rate, for example, around 25 ml per kg actually. So you have to little bit set your effluent flow rate on the higher side, because sometimes it has been found that if you set a rate of around 35 ml, actually your machines remove the 30 ml per kg actually the effluent flow, and that what ultimately determines your dialysate rate and the replacement fluid rate. Am I right, sir? Sir, I think sir has joined.
You continue. Hello,
Yeah.
Can you hear me?
Yes. Yes.
Oh, all right. So the internet is really unstable today. I'm really sorry for my part. But as we are coming to that, so you have seen that one thing you have to remember, that is the filtration fraction. The filtration fraction basically, so this was I was telling about you. That is, suppose 100 ml you want to remove, but in the last hour you have given 200 ml at test tube feeds and 100 ml for vancomycin you have given. So you have given 300 ml. And in the drain, you have 50 ml and the urine output is 120 ml. So if you want to remove 100 ml, you have to, patient fluid removal to be set in the machine is 100 plus 300, because 300 is non-CRRT intake, 200 ml feed plus 100 ml injection, that is 300. So 100 plus 300, and the output is 50 plus 120, 170. So this 100 plus 300 minus 170. So you have to feed 230 ml in the machine. Then only you can remove 100 ml. Most of the time we put 100 ml, give fluid from outside and saying CRRT is not working because my patient is getting bloated, my patient is gaining weight. So that is the problem they have to remember. And the filtration fraction is nothing to do with the dialysate. It is only the ultrafiltration. You have to keep the filtration fraction below 25% when you set it so that your filter does not clog. So when you prescribe like this type of therapy, filter, blood flow, pre-dilution, post-dilution, dialysate, patient fluid removal, what type of anticoagulant you are using, effluent rate, effective dose, and zero balance to negative balance. Now, see this one. So Ronco told in 2000 that maybe the effluent of 45 ml or 35 ml is better than 20 ml. The same thing was still 2006, it was going around the higher values, 40, 45 to 25. But two trials came, ATN trial and renal trial. In both the trials, it was found that around 35 to 40 ml per kg per hour versus 20 to 25 ml per kg per hour, no difference in patients. So, but again, these are in patients of AKI. So, 25 ml per kg per hour. So, what KDIGO said, still continuing, 20 to 25 ml per kg per hour of CRRT, that is the effluent dose is the dose that is to be given. Now, the point is, do you really reach this dose? Because you have a lot of delivered dose versus prescribed dose. The Dorabi study, they found if you start at 35, you come out at 26. And if you start at 25 ml, you have a lot of stoppage, nursing stop, effluent back change, usual downtime, technical downtime. So you come down much less. So prescribe more to achieve what you want to achieve. So if you want to go for 20 to 25, start with 35 ml per kg per hour because you have to stop in between. So this you have to remember. And when to stop, again, there is no guideline. We say if the urine output is coming up well, maybe more than 500 ml per hour, per day, or the intradialytic urinary creatinine is good, it is rising. So that means the patient is having the renal function is coming up. If you are hemodynamically stable, you can then change to your non-CRRT counterparts, that is the intermittent counterparts by SLED or IHT. Now, why CRRT over SLED and IHT? Because it is more physiological. There is a 24-hour support. Obviously, your kidneys are gone. Why to give a support for 12 hours and keep the kidneys exposed to the toxins for another 12 hours? So this is the basic concept. And it is much smoother. Obviously, rapid intercompartmental shifts are found in hemodialysis. That is not there. They're hemodynamically stable. You are quite confident about the dosing. Lot of studies are there. Good volume control, removal of the middle molecules that can be done by hemodialysis. Very good in cerebral pulmonary edema and renal recovery. Remember, antibiotics, I'm not going to the details of this, but do not compromise with the loading dose. It is the maintenance dose sometimes has to be changed. In fact, most of the antibiotics are cleared by CRRT. Therapeutic drug monitoring is the best, but most of us can't do it. It has been seen even in kids. Those might have high glycosides. Most of this situation, the dose has to be adjusted because most of the time, if the TDM is not there, then in certain situations, especially for cholesterol, many times you have to increase the dose in cases of CRRT because most of them are removed by the renal replacement therapy. Malnutrition is a big problem. Do not forget about malnutrition. We call it depletion syndrome. Lot of amino acids, selenium, zinc, fat, glucose, water, soluble vitamins are removed. So normally, we have to give good amount of nutrition to the patient. Do not restrict on your proteins if your patient is only on AKI. Do not restrict on your proteins. In hypercatabolic state, you have to increase your proteins to maybe 7 grams per kg per day. Now, the last slide, I hope. Many times we intensivists think, should we do this one? Should the nephrologist be involved? We have come out from ISCC with white papers and with guidelines where renal replacement therapy, especially the continuous form, is an integral part of our curriculum. Most of us are trained nowadays with this, so we can jolly well go for it, don't worry. But most of the problem is the awareness, the eagerness, and the good teamwork and coordination in between, the availability of consumables. Forget all these things. and a good administration, very important. Then only you can go for a standard ICU care, go for a good CRRT, go for this type of therapies, which are definitely costlier than others. So, thank you so much. And I'm really sorry for the disturbance that went on in between. And I'll be happy if you ask me some questions.
Thank you, Dada, for this wonderful presentation. It was lovely insight into the topic, and many a times it is very difficult to understand how to adjust the dialysate, replacement, and blood flow. And very often, the intensivists feel that by increasing the blood flow, the patient is going to get compromised, but it's not like that. Okay, every parameter is interlinked with each other, whether dialysate or replacement or blood flow or ultrafiltrate. All these need to be cautiously calculated, and effluent calculation is very important. We need to overdo with the effluent calculations probably, and then ultimately what we achieve is less only, because downtime, the nursing interruptions are also very common. And it is very important to understand what type of dialysis we need to do, whether it is a slade or scuff or CVVSD or CVVH or CVVSDF. So I think you have given a good insight about the different modes of dialysis. I have few questions, Dada, if you would like to take this. Like, very often it has been seen that in rhabdomyolysis or in patients with resistant hyperkalemia, it becomes very difficult to adjust the dialysis flow. The dialysate adjustment is very difficult, especially with this rhabdomyolysis. Crush syndrome patient, polytrauma patient comes up with us, and then we often keep changing, dialysate and try to keep dialysate at very high doses. Is there any other way to take care of this rhabdomyolysis with hyperkalemia, persistent resistant hyperkalemia? Would you like, or do we need to use specialized filters?
The only way is that we have to increase if the patient is hemodynamically stable, and obviously we should go for, in this situation, the better is to go for an intermittent counterpart, because
Yeah.
if the patient is hemodynamically stable, uh, intermittent hemodialysis is better rather than continuous therapies. Because in continuous therapy, you go for a blood flow of around 150 ml to 200 ml per hour. There you go up to 500 ml. The dialysate quality is better in intermittent hemodialysis. They do it very quickly. Here, CRRT is a bit slow, and that is the reason. But if the patient is hemodynamically unstable, then we have no other choice, but we have to go for, again, I told you, because in dialysis, there, when you are doing CVVHD, you can go to a blood, if you give a blood from 150 ml, then you can go for a dialysis of 3000 ml, more or less. You see, because 3000 divided by 60, it comes around, say 50, the 50 into 3, 150 ml of blood flow, you can go up to 3000 ml of dialysis. So that you can go, if maximum up to that. But it is better that if we go in these situations with the help of your intermediate counterparts.
So basically, this
what I feel.
Rhabdomyolysis is basically
blood flow. It is the blood flow which will help us to achieve more clearance rather than.
It is mainly the blood flow. Mainly the blood flow. Yes.
Yeah.
Yes. And the ratio is like that. All right. Somebody is asking about CRRT in lactic acidosis. CRRT is not very effective in lactic acidosis. It normally, though the certain literature claims that it removes lactate by around 50%, 70%. Both of us, those we are working, Gunadhar will also be.
Yes.
And Akhilesh, you must be also agreeing with me, because unless the septic process is stopped, lactate level will be going on. CRRT is not very effective in removing that extra amount of lactate. And neither the way is that the whole thing has to be taken as a whole, rather than only CRRT machine that will remove everything. So lactate, I don't have very good experience with the lactate level. More or less, it is not very effective in removing it. Suppose it's 14, it will not decrease it to 2 or 1. Yes, it will come down, but it will not come down in the magnitude that you want.
So actually, for the lactate clearance, we need to find out what is the cause of the hyperlactatemia. And second thing is like CRRT is not a treatment or SLADE is not a treatment. It just clears. SLADE clears more effectively compared to CRRT, but you have to find out whether it is a sepsis or whether it is liver failure or what you can do to support the organ system. That is actually the thing. Am I right, sir?
Yes, yes, you're right. Normally, in CVVH, if you're doing a CVVH, the lactate clearance a bit more than the CVVHD. So if you're doing an ultrafiltration, it has been seen that it clears more or less doubling the lactate clearance that of a diffusive treatment. So that has been seen. But otherwise, lactate, I am not very convinced.
So I have just one comment regarding this rhabdomyolysis. Yeah, for the rhabdomyolysis, as you rightly told, like if the patient is hemodynamically unstable, sometimes like in these cases, CRRT helps. And sometimes this is a one situation where the dialysate flow rate is, you have to set very, very high, because the most important danger to the life is in this case is severe life-threatening acute refractory hyperkalemia. And so you have to treat the hyperkalemia, and that is where the dialysate in this situation, you need a very high dialysate rate. And people have used actually, sir also, I think must be agreeing, 2 CRRT machines sometimes in case of severe life-threatening this rhabdomyolysis actually. So this is what one point from my side. Yeah.
When to start CRRT in sepsis or ARDS? Amir Saeed is asking. I think I have explained it very well out there. So I have given you a chart where I have shown exactly when to start.
Yes. So just for the understanding.
Again, to explain it, yes, please.
Yes, sir. No, I think you have already made it very. Please go on. So just for the understanding for the basic, like for the CRRT, so just if you can, sir, explain the dosing schedule. For example, a 50 kg male on septic shock or requiring a CRRT. So how do you like adjust how do you start the initial setting and how do like adjust the setting of the CRRT?
So suppose I am with a 50 kg male coming with a septic shock. Now, very easy to start because with a CVV HDF, I select CVV HDF. Now, for 20 to 25 ml per kg per hour, I'll give around 30 to 35 ml per kg per hour. So around 1500 to 2000 ml should be the effluent volume. If 2000 ml is the effluent volume, I divide it equally between dialysate and ultrafiltrate, 1000. And if the patient is a bit volume overloaded, then I add a patient fluid removal of suppose 100 ml per hour. If I'm giving something from outside, I also add it to it. So if I want to remove 100 ml, I'll add 200 ml to it. So that will basically make it 100 ml per hour. So I add that also. And initial stages, as in the sepsis, obviously you give more fluid to the patient. I don't want to remove it because the first fluid resuscitation is going on in the first 3 hours. I'll go for maybe a zero balance CRRT, that's what I told you, CVV HDF. Now, after some time, I see that the hypercatabolism is slowly coming down and the patient is having only high creatinine. So I can shift to CVVHD. Or if the patient is having, I want the patient to correct the metabolic acidosis first. So again, I can do a CVVHD. But I have to remove a mode of extra fluid and that toxic middle molecules from the patient because sepsis is still continuing. I will continue either with CVV-HDF or with CVVH. So in this way, I shift. That shifting is important from one patient. Nobody can guide that exactly when to start what. You have to check the patients in between. If we want to remove more of creatinine, urea, I'll go for dialysis. I want to correct the volume overload, I go for ultrafiltration. I only want to remove that extra amount of fluid from the pulmonary circuit, I only go for scuff. So in this way, I juggle between, and now I suppose liver failure. So the ammonia level is going up. Then I have to go for a high ultrafiltration. I only have a small amount of cerebral edema. I don't have to treat anything else. I come down to my dose of ultrafiltration to around 13 ml, much lower than what is needed. So this is the way I juggle my CRRT in order to optimally utilize it. So there is no guidelines. Nobody can give you the guideline. But obviously, this is the way we start. Around divide it into 2 parts. And the replacement fluid, that is the ultrafiltrate 1000, if it is there, I give 300 pre-filter and 700 post-filter. 1/3, 2/3. So 1000 dialysis, 300 pre-filter, 700 post-filter, 1000, another 1000, and maybe 200 ml per hour of patient removal or 100 ml per hour of patient removal according to the calculation that I showed, that I have to. And I have used both citrate or heparin. I prefer heparin or no anticoagulation. I give flush my circuit. You also might be flushing your circuits with around 100-150 ml of normal saline. Remember that what I am flushing has to be removed. So that has to be put into that patient fluid removal in the next hour or so. That I am giving 150 ml more to the patient. I don't want to overload my patient. So I'll remove it. So in the third or the fourth day of CRRT, I go for a negative balance CRRT. In the first or second day of the CRRT, that is in the sepsis, and the first day of the second, when I'm resuscitating the patient, I'll go for a zero balance. On the third and the fourth day, when we're in the stabilization and the evacuation stage, I'll go for a negative balance. This is the way we alter it as per the patients.
Yes, absolutely.
Basically, the more we do it, the more we learn and the more we change.
So is there any relationship between the ultrafiltrate rate and the replacement fluid that you are giving actually?
Yes. Whatever I am replacing, that is being ultrafiltered. So suppose I am doing a pre-filter of 300 and post-filter of 700 replacement. So I am giving 1000. So that 1000 will be read by the machine that I have to filter the 1000 ml. In the effluent bag, the 1000 ml will come out as an ultrafiltrate, the pathological fluid. Also, the 1000 ml of dialysis will also come. The replacement is the machine reading it as ultrafiltrate. That is the amount of ultrafiltration going on, which I am replacing back to the patient. Otherwise, the patient will become completely dehydrated if I remove that. That is the reason of giving replacement.
Yes.
This basic thing, this concept takes at least 2-3 years to understand. Why I am giving replacement fluid.
Correct. Absolutely.
Why? What is the ultrafiltrate then? So what is patient fluid removal? Because if you go to another machine, I don't want to the name, there it is net ultrafiltration. That is patient fluid removal. Whereas in this machine, it is patient fluid removal. So the terminologies are also different.
Correct. That is very tricky actually. Sometimes it may be confusing, but one should be very much
sometimes very tricky. It takes some time.
Yes. So there is
another
something
thing.
called
The problem that comes, one or two problems that I had to discuss. When you are doing a CRRT, your patient should be absolutely not moving. So most of the times when the patient is intubated, CRRT is the best thing.
Yes.
The moment the patient is moving, your CRRT get disturbed because the blood flow get disturbed. And if you are put a femoral catheter, try to abduct your leg a bit. And keep your patient, if you're putting it in an angle, if the patient is in 40 degrees head up, sometimes your femoral catheter might get kicked. Your CRRT might get stopped. So that you have to see. Sometimes you have to angulate your leg a bit, abduct your leg a bit. And if you're doing obviously internal jugular, that doesn't disturb much. But most of the time, you have already a CVP line there. So you have no other choice but to put a femoral line for your CRRT.
Right, sir. And like sometimes your machine also gives some kind of alarms like positive fluid gain, negative fluid gain, and that also you have to take care actually sometimes. If you
so this machine is very sensitive. It can allow up to a fluid gain of 400 ml. So the Prismaflex allows up to 400 ml of fluid. The moment you are gaining that, going more over that, it will stop. So do not touch your machine unnecessarily. If you touch it, you give a gain of around 10 ml, 20 ml like that. So do not touch it. Number one, it has a lot of pressures inside. Excess pressure is always negative. Obviously, you are sucking out the blood. The excess pressure is negative, minus 50 to 150. Return pressure is positive, plus 50 to 150. You have something called transmembrane pressure. If it is rising, that means your filter is clogging. You have something called filter pressure drop. So these things I have not discussed because obviously, if you do a workshop, there only we discuss this type of things. And you have to look after definitely the pressures. Yes, they are very practical things. This is basically, I left that slide purposefully for that.
Any other questions in the chat box? I don't think. I think most of the things are being covered actually.
No, there are only 2 questions. Both the questions has been answered. Swati Agarwal, she is asking how to increase the solute clearance. So solutes are, most of these are small molecules. Urea, creatinine, potassium, sodium, these are small molecules. So in order to increase the solute clearance, you increase the blood flow and increase the rate of the dialysis. What Akhilesh and Dr. Gunadhar was telling you, that during hyperkalemia, you have to increase the blood flow and the dialysis rate to remove that extra amount of potassium from the patient. So solutes, if you want to remove the solute, only solute, you can very well go for continuous venovenous hemodialysis. But if you are going for remove the middle molecules, again you think that you have to go for that ultrafiltration. So that is how can you remove solute clearance. Now see, there are so many other things also. If you take another class, then we can discuss about the hypotension during CRRT, how hypernatremia and hyponatremia is managed with the CRRT, because your fluid has 140 milliequivalent per liter of potassium, sodium. So your patient, if the patient is hyponatremic, so a lot of sodium will go to the patient. If you have 110, patient sodium is 110, Prismasol is 140. So there's a gradient, huge gradient. Here what will happen? There will be a rapid rise of sodium in the patient. So there we have to do something. How to manage that? Or your patient's sodium is 180, this sodium is 140. Now there will be a huge gradient from patient to the that is up to the dialysis. So what will happen? The drop will be very fast. So what to do there? So these are other intricacies of CRRT that can be discussed if we get a time later, or you go and read it. There are good papers on this, you can understand. Or if you are doing CRRT, or a consultant will explain. I think.
Thank you, sir. Thank you very much.
We can call it a day before my internet again goes off.
Yes, absolutely. So
Thank
wonderful.
you, Ranajit Dada. Thank you very much. Thank you. Thank you, all the audience and
Thank you so much.
the other panelists. We had a wonderful insights from Dr. Ranajit Chatterjee today. It was lovely and eye-opener presentation from your side, Dada. With these intricacies, even if we read more often, you get to know something more when we, listen to the talks like you have presented.
Exactly.
So it's a continuous process. Learning is a continuous process. Each day we will be able to learn. So keep getting updated more often. That is the only way to keep yourself, justified in treating patients with the complex clinical conditions. With this, we'll conclude this session today. It was really an honor and privilege to have you with us, Dr. Ranajit, and hope to see you more often again and again. And we would like to conclude this session today and hope to keep some questions later on also. You can keep the questions on the chat box, or you can send it to the email address, and then we will be able to answer all your questions and queries. So we'll wind up the session today. Bye bye. Good night, everyone. Thank you, everyone. Thank you, Dr. Ranajit.
Thank you so much.
Thank you,
Gunadhar, Dr. Gunadhar. Thank you, Dr. Akhilesh. Thank you. Thank you. Bye bye.